think we have a few people, and people will sort of trickle in. So I think we can get started. I'll just quickly introduce you for those of you who don't know you. Today we have Dr. Dean Kereiakes as the speaker today, and we're really grateful that he took time out to talk to all of us about this wonderful topic on stents, balloons, and lithotripsy. So Dr. Kereiakes, he's the president of the Christ Hospital Heart and Vascular Institute. He's medical director of the Christ Hospital Research Institute, and he's professor of clinical medicine at The Ohio State University. Thank you again, Dr. Kereiakes, for taking time to talk to us today.
You're very welcome. Thanks for having me. I want to particularly thank Alexander Lansky for giving me such a gracious invitation. You know, I'm going to talk about coronary interventional technology and evolution, stents, many concepts in stent design, some of you may not have considered, drug-coated, drug-eluting balloons, and of course, intravascular lithotripsy. It's a massive amount of information. I think there's something for everybody, a potpourri of technology. I'm going to try to go through this in about 45 minutes or less. If you could hold your questions to the end, we'll clearly have time for it. You know, I've been trying to forward these slides. There we go. I told you there is always a hitch when you do remote. I've been a consultant for most of the catheter companies for the last 25 years. And you know, over the last 25 years, there's been a remarkable evolution of PCI technology, from bare metal stent to first and then second generation DES. And through that evolution, you've seen a progressive stepwise reduction in adverse stent-related events to 1 year, whether it's the device-oriented composite endpoint or target lesion failure is shown, and I'll come back to that in a moment, or simply stent thrombosis. The lowest incidence of events from implantation to 1 year is seen with second-gen DES compared to first-gen DES or bare metal stent. And although you see this progressive reduction of events to 1 year, as you can see, beyond 1 year, there appears to be a 2 to 3% per year annualized rate of events, regardless of device. Probably the major driver in this progressive reduction in adverse events has been a progressive reduction in stent strut thickness. For this network meta-analysis, 66 trials, 75,000 patients. On the left, you can see a progressive stepwise reduction in stent strut thickness is associated with a progressive stepwise reduction in stent thrombosis. Similar progressive relationship for major adverse cardiovascular event and myocardial infarction also demonstrated, all of which point to the concept that thinner is better when it comes to coronary stent struts. A contemporary classification DES by strut thickness has been offered by Shripal Bangalore. I think this has been embraced. This will be important to keep this in mind going forward to the next couple of analyses. You have a thick strut if you're greater than 100 micron. Thin is 70 to 100. This is most of the workhorse devices that you have in your hands. And ultra thin is less than 70 micron. When Shripal took the 3 ultra-thin bioresorbable polymer DES listed down here at the bottom, Orsiro available in the US, MyStent, BioMine available outside the US, all are sub-70 micron strut thickness, bundled them together and compared them to all other contemporary DES with respect to clinical outcomes in a meta-analysis of 10 trials, 12,000 patients. He found a statistically significant 20% reduction in target lesion failure, 20% reduction myocardial infarction, and almost a 30% reduction in stent thrombosis. If you expand this type of an analysis to now include 16 randomized trials, 21,000 patient mean follow-up of 31 months, comparing ultra-thin, less than 70, to thin, which is 70 to 100, you again have a 15% relative reduction in target lesion failure, 15% reduction in stent thrombosis. In the largest meta-analysis to date, which I think you can see here, is almost 100,000 patients. Comparing the ultra-thin, 60 micron thin Orsiro, to the thin 81 micron Xience, thin 89 micron Resolute, or thick Novorio Biomatrix, there is consistency in the observation of a significant reduction in target lesion failure to 1 year. You know that stent strut thickness impacts healing and inflammation in stents. If you look on the left This shows the inverse relationship between strut thickness and the degree of strut coverage in a finite period of time. This is 14 days in a rabbit. Thicker strut, less coverage, more fibrin, more inflammation, greater injury index. Strut thickness affects thrombogenicity. On the bottom right, you know this, a thicker strut creates a zone of low shear stress downstream behind the strut that is intrinsically thrombogenic. You know, this direct relationship between strut thickness and adverse clinical outcomes appears to be magnified in smaller vessels. This is the pre-specified analysis of small, that's a reference vessel diameter less than 2.5 millimeter. BIORESORT analysis out to 3 years. These are all small vessels. BIORESORT, of course, randomized patients to 1:1:1 to either Resolute, Synergy, or Orsiro, and the strut thicknesses are shown adjacent to the stent name. What you can see for target lesion failure, target lesion revascularization appears to be almost a progressive stepwise reduction in adverse events over time through 3 years in favor of the thinnest strut device. This is magnified further by giving a 1-year landmark. If you look beyond 1 year, the difference between the thicker Resolute and the thinner Orsiro becomes highly statistically significant. And it looks like it may impact the annualized rate of events. These data get further support, if you will, from the SCAR registry, you know, the Swedish Coronary Angiography and Angioplasty registry, looking at small vessels, that's 2.5 or less. And you compare the ultra thin Orsiro at 60 micron compared to all other new generation DES. You again see on the left, 10% reduction in stent thrombosis through 2 years, and on the right, highly significant, 25% reduction in target lesion revascularization. And again, the curves appear to diverge over time, favoring the ultra thin device. You know, in editorial comment, my good friend Antonio Colombo looked at the advantages and disadvantages of ultra thin DES. He suggests they have easier deliverability, less thrombogenicity, better vascular healing, less footprint effect, and he cautions that they theoretically may have less radial force, particularly in reference to calcific and fibrotic lesions. That's a reference to the PRISM 4 trial that I'll get to in a second. You know, I think there's never, in the era of novel stent metal alloys, cobalt chrome, platinum chrome, there's never been any convincing data that the ultra thin device has inadequate radial force. In the PRISM 4 trial, that pitted in randomized fashion of 0 at 60 micron, which is at 81, following CTO recanalization, suggests the trial was fraught with methodologic flaws, and I think play of chance with respect to the lowest latent loss ever reported with design stent in that trial. So I think the data, although theoretic, are not real at this point for inadequate radial force. You know, the BIONYX trial gives us other really good insights, I think, into the importance of strut geometry and how this may in part mitigate strut thickness. Let me explain. BIONYX randomly assigned 2,500 all-comers to treatment with either the thin 81 micron but round strut Resolute, or the ultra thin 60 micron thick but square strut Orsiro. Target vessel failure at 1 year is the primary endpoint. On the left, no difference in target vessel failure to 1 year. On the right, almost surprising, about a 90% relative reduction in stent thrombosis, favoring the thicker but rounder strut ONYX compared to the thinner but square strut Orsiro. You should also know that there were 38 2mm stents in the ONYX group, none of which had a thrombotic problem. There were no 2mm stents in the Orsiro group. The smallest stent diameter there is 2.25. You know that smaller stent diameters have increased incidence of thrombosis. In the isolated thrombotic event that occurred in the Orsiro treated group was a patient who got over 100. In the ONYX treated group, I apologize, is a patient that got over 100 millimeters of stent and inappropriately stopped their DAT within 30 days. Some call this a fluke, play a chance at the aberration you can get in some large scale trials. You know, I'm not so sure about that when you follow these patients out for 2 years. You lose some power, but there persists a 62% relative reduction in stent thrombosis in 2 years in favor of the thicker but rounded strut ONYX compared to the thinner but square strut Orsiro. So play a chance. I think this is part, it could be operative, but I think there's also, play of stent strut geometry that can impact shear stress distribution profile and shear stress abnormalities. Of all the stent strut profiles that you see, the worst as far as shear stress distribution, shear stress abnormalities is square struts. That's exactly what we've been putting in for the most part over the past 25 years. ONYX is circular, round, made from a wire. All of the other profiles, whether it's circular, elliptical, or teardrop, have better shear stress distribution profile, less shear stress abnormality. If you deploy the top two here, circular and square, at a 16 atmospheric pressure, in general, a greater degree of stent embedment occurs with the rounder device. The square behaves more like a snowshoe, the rounder more like an ice skate, if you will, on the endoluminal surface. That can impact the rate of coverage and healing, can also impact the rate of delivery, the ease of delivery, in that they're less likely rounded struts to be engaged by calcified ridges or even other stent struts en route to the target. So if I said in brief interim summary, I think thinner stent struts heal more rapidly and completely, less injury inflammation, and are less thrombogenic. These are all true. Stent strut thickness and width. In the interest of time, I've taken those slides out. We can talk about at the end. This is what sunk the absorbed bioresorbable vascular scaffold, was the combination of thickness and width, which equals strut volume, that becomes progressively more important in small vessels. Strut geometry can affect the degree of strut embedment, the rate of healing and coverage, peri-strut shear stress. And although thinner is better, at the end of the day, I think thinner and rounder may just be best. And you may hear more about that when the svelte stent is approved next year. We'll talk about that briefly in a minute. I think they'll purport that these are rounded struts due to very aggressive polishing. And I think Medtronic could have and really should make more of what they have as an intrinsic advantage. Other stent design iterations that can impact stent or device-related events, particularly the composite endpoint of target lesion failure. This is the combination of safety and effectiveness endpoint embraced by the US FDA for new device approval. It includes a composite of cardiac death, target vessel-related MI, and ischemia-driven target lesion revascularization, or even stent thrombosis. Top on the list, as we've already discussed, and probably the most powerful influence is strut thickness. Other things that have been evaluated extensively include polymer. This is polymer composition, distribution, whether it's abluminal only on the outside of the stent strut or conformal surrounding the strut, polymer load, and time course of polymer absorption, whether it's durable, permanent, or bioresorbable. We'll come back to that in a minute. The other iteration was platform flexibility and conformability. This impacts geometric distortion of the vessel, which can impact fracture resistance. Fracture is an important mode of stent failure and presents as thrombosis or restenosis. And I think all of you guys have seen this graphic. I actually worked with biomedical engineers, graphic artists at Boston Scientific to create this graphic for the first time in the wake of Evolve 2 prior to the release of the Synergy stent, the first bioabsorbable polymer DES approved in the US. It shows the time course of polymer resorption for the metallic bioresorbable DES in purple, and for the bioresorbable scaffolds that were available at the time in green. If you go to the top of the tree, so to speak, the most rapid absorption, these are all PLGA with varying LG ratios. So that's the most rapidly absorbed PLA derivative, if you will. This is lactic to glycolic acid ratio. Buma Supreme myosin of 50-50 LG ratios, polymer absorption is in 45 to 60 days. I'd call out that Buma Supreme should get approval in 22, I hope early in 22. Alexandra Lansky was co-PI in North America for this trial. His first author on the pivotal Pioneer 3 IDE trial publication. Synergy has an 85-15 LG ratio polymer absorption over 3 to 4 months. We're going to touch on elixir dynamics. I hope you'll see this in an IDE trial in 22. It's an 85-15, but it comes out to 6 months because it's really a bilayer with PLLA. We're going to see this in a minute. It's a dual polymer on the surface of the strut. The only one that's not a PLA derivative, it's kind of novel, that should be approved next year as well, is Felt, which has a unique amino acid composite called PEA that resorbs in about 12 months. And it has some specific attributes that are attractive as a drug carrier as well. This was the pivotal trial for US FDA approval of Synergy Stent, the first bioabsorbable polymer DES approved by the FDA. It pits 1,684 patients, one-to-one randomized, that are diametrically different in polymer composition, distribution, and time course for resorption. In one corner, you've got Synergy with an ultra-thin 4-micron thin abluminal only on the outside of the stent, so PLGA that resorbs in 3 to 4 months. In the other corner, you've got Chromis Element Plus that has a conformal surrounding the strut 7.8 micron thick PVDF fluorocopolymer, same polymer that was on Xience that revolutionized the second generation of DES. Despite the marked differences in the design of those two devices, no difference in target lesion failure at 1 year. Surprisingly to me, no difference through 5 years. Even the annualized rate with 1 year landmark is not different. Bangalore again took this to a different level. In 16 trials, 20,000 patients, comparing bioabsorbable DES to novel second-gen permanent polymer DES, no difference. Target vessel failure, myocardial infarction, cardiac death, stent thrombosis, no difference in short or long-term outcomes. Although it had great theoretic appeal, in practice, bioabsorbable polymer DES have not differentiated themselves. Now, fracture, is a common mode of stent failure. Our peripheral colleagues, they've known this for years. They use the big, thick nitinol stents in the periphery. They can see fractures, and they know fractures associated with thrombosis and restenosis. Fractures more common with DES. This is the theory of Renu Gramani. On the right, you see a DES has much less neointimal coverage, less support applied to the platform, greater flexion is applied to the platform, versus BMS on the right with greater neointimal coverage, greater support given to the platform, and less flexion transmitted to the platform. Fracture is common. If you look on the left, it was identified in 22% contemporary DES followed for 3 years, and this is radiographically, which is a crude measure, probably underestimates. And nevertheless, patients with fracture had a highly significant increase in in-stent restenosis, target lesion revascularization, definite stent thrombosis. This is a really busy slide. I apologize for the clutter, but it summarizes multivariate analysis of 3 large series of predictors of stent fracture. The commonality across these 3 separate multivariable analyses include hinge motion, including osteo location, tortuosity, including right coronary target, stent length, and stent overlap. These are common findings across multiple multivariate analyses. This is a ginormous stent flexion model. It shows that stent platform flexibility correlates directly with fracture resistance. He takes one end of an 8mm stent segment, locks it in a static post, he moves the other end back and forth through 12-degree flexion arc. After 10 million cycles, the most flexible devices are shown here on the right. They have the fewest fractures, most intact devices. The less flexible devices are over here on the left, more fracture, fewer intact devices. This includes the less flexible Xience with multi-link frame, the more flexible Chromis Element here, which has 2 connectors between rings throughout the body of the device. And we're going to see head-on clinical comparison of these in a minute. Well, flexibility, conformability impacts geometric distortion of the vessel. We know that baseline vessel angulation exceeding 33 degrees or a change in vessel angulation greater than 9 degrees have both been identified by multivariate analysis as significant independent predictors of MACE, particularly restenosis. Geometric distortion can create abnormalities in coronary flow velocity and shear stress, as you can see on the left, that are greatest at the stent margins. And those abnormalities have been correlated, as shown here on the right, with DES restenosis. And these are Cypher stents, which is very effective anti-restenotic technology. Nevertheless, when you compare the less flexible cobalt chrome Xions to the more flexible platinum chrome Polis, this is the pivotal trial, 1,500 patients, head-to-head, one-to-one randomization. As you can see, through 5-year follow-up, there was no difference in target lesion failure, device-oriented composite endpoint. And with a 1-year landmark, the difference here is about 1.25% per year annual rate. Doesn't reach statistical significance. So again, despite the theory in practice, this has not really worked out. I think any of you that are old enough to have put in mirror stents remember the geometric distortion of the vessel. I think it's intuitively unattractive and not something in linked to fracture. We know that. So I think in general, although I can say the theory is very good, the hard data and support, just not there yet. It's not something I've given up on. In summary of what we know about metallic prostheses, I'd say they constrain and distort the vessel, they limit vasal motion, autoregulation, and most important, as a line item, the number one issue of metallic prostheses is preventing positive adaptive vessel remodeling. This is an incredibly important protective mechanism for all of our arteries to accommodate atherosclerosis. They provide a persistent nidus for inflammation, neoatherosclerosis, thrombosis. They can be prone to fracture. It presents as restenosis and thrombosis. And all of the above contribute to that 2 to 3% annualized rate of device-related events, extending out to at least 10 to 15 years, for which we have good follow-up. I think this is an important graphic that Greg Stone and I showed the US FDA in support of the IDE for the Absorb 3 trial. This is a pivotal trial for FDA approval of the avascular bioresorbable vascular scaffold. And this graphic supports the concept, if you will, of leave nothing behind. This graphic depicts 1,500 patients undergoing primary PCI for STEMI at Moses Cone Hospital by our friends Bruce Brody, Thomas Stuckey. These patients are treated with balloon angioplasty, bare metal stent, and first-gen DES. What you see on the left is stent or lesion thrombosis, on the right, target vessel infarction. As you can see, to 1 year, stents provide at least a numeric advantage for reduction in these adverse events compared to balloon angioplasty. But beyond 1 year out to 9 years, there is a highly statistically significant reduction in adverse events following balloon angioplasty, which suggests that leaving nothing behind is associated with a lower annualized rate of events compared to stent, regardless whether the stent was DES or BMS. So the commonality of incremental event rate with DES BMS appears to support the concept that this is due to the persistent metal frame that constrains or distorts the vessel. The concept of leave nothing behind. You know, this certainly was attractive. Many of you and myself thought this would be the future of coronary stenting. The concept that you can get mechanical support similar to a metal device for at least 6 months to prevent recoil and negative early remodeling, followed by bulk resorption with the restoration of vasal motion, adaptive positive vessel remodeling. Certainly looked to be the case here in pig arteries. This is histopathology on the top. You can see gradual resorption of the scaffold and the concurrent optical coherence tomography, intravascular imaging, where the struts are resorbing and there's an increase in luminary consistent with positive adaptive vessel remodeling. Some of the early reports that came from humans were tantalizing. I think this created a feeding frenzy, so to speak. When you look at, and this is in 2014, gradual resorption of the scaffold, a reduction in plaque area, increase in luminary, and this golden halo, if you will, thin rim of neonatal hyperplasia that would seal plaques. Well, this was incredibly promising, and everybody was saying, we want this in our LAD. We don't want a metallic device. Then came the reality, okay? And the reality I'm going to show you is a meta-analysis of 4 trials, Absorb 2, 3, Japan and China, 3,400 patients. These curves are virtually identical to the curves for Absorb 3, which was 2008 of these 3,400 patients we put in circulation. And I think this is important because the landmark that I've drawn here in 3 years is generally accepted as the time course of complete scaffold resorption in humans. I know there's some contention over this. There's some fragments identified out even to 4 years, but in general, this is the line in the sand for complete scaffold resorption in humans. And what you see in head-on randomized comparison is that to 3 years, there's a 42% highly significant increase in target lesion failure with BVS compared to Xience, but beyond 3 years, now to 5 years, which is the limitation of follow-up in all these trials, unfortunately, there's an abrupt 8% reduction. So a flip-flop, and the p-value for interaction signifying a statistically significant treatment effect benefit over time reaches statistical significance. This is much more dramatic when you look at device thrombosis. This is powerful. This is a combination of graphics I put together. I took the top part from the JAMA Cardiology meta-analysis. Then I put in an editorial called BBS Deja Vu, the storm, which is the first 3 years, for the calm after 3 years. And what you see to 3 years is a 3.9 hazard ratio increase in thrombosis, BBS compared to Xience. Beyond 3 years, an abrupt flip-flop, 60% relative reduction in device thrombosis with BBS compared to Xience. The etiology of this storm, so to speak, I've outlined below here, includes strut thickness with shear stress disturbance, early discontinuity, fracture, malappositions due to polymer processing characteristics and physical chemical properties of the device itself, and then something characteristic of bioresorbable scaffolds that can be a problem as we go forward, and that is interluminal scaffold dismantling. This is late discontinuity where fragments of the device, if they're not tucked down by neointimal hyperplasia or endothelial coverage, they can fall like ceiling tiles into the lumen, and as you can see here, create thrombosis or restenosis. Beyond 3 years, the metallic device cages the vessel. The lumen can only go in one direction, the wrong direction, as it fills with neointimal hyperplasia, neoatherosclerosis, and thrombosis. But beyond 3 years, here on the right is the BBS, the scaffold resort, and the process of positive adaptive vessel remodeling has been restored with an increase in luminary to accommodate subsequent atherosclerosis. So that's the, I think the field is not dead, but I think there's going to be a real hard look at the physical chemical properties of polymer and time course resorption. I think in 22, you will hopefully, if you haven't already seen this, see what is probably the most significant iteration in metallic implant design of the last 20, 25 years. This is called the Dynamics Bioadapter. It's on the threshold of ultra thin. It's a 71 micron thin cobalt chrome platform that has a conformal bi-layer polymer. The outer 3 microns are PLGA, the inner 6 microns are PLLA, and the drug is nivolumab, and it goes swapped in polymers. The polymer absorbs over 3 to 6 months. These struts can uncage, disengage, and restore the capacity for vasomotion and adaptive positive vessel remodeling. Dynamics uncaged appears to restore pulsatility and cyclic strain. This is from the 50-patient proof of concept trial published by Stefan Verhey and Antonio Colombo. These are stationary OCT core lab analyses, co-registered images. These are taken, and there's multiple patients that had this 9 to 12 months out following device implantation, past the point of polymer resorption. What you see is systematic variance in lumen and stent area between systole and diastole. Dynamics uncaged appears to reduce geometric distortion. Uncaging is associated with a 60% increase in conformability. On the left is a 120-degree angled mid-LED target following a 3.5 by 18 dynamics bioadapter. There's more than a 10-degree angle shift in this target, which should be prognostic. And at 12 months, the artery appears to have resumed its normal configuration. Now, this is not perfect, but when you look at the QCA independent core lab analysis, there is a highly statistically significant difference between the core lab determined angulation post-implant and in late 9 to 12 month follow-up. A dynamics uncaged appears to restore a positive adaptive vessel remodeling. This is serial in vivo OCT evaluation, adult porcine coronary model. Vertical axis here is mean area of the lumen in green, the device in orange. The reduction in lumen area reflects the development of neonatal hyperplasia, but you see it recovers back to baseline and beyond with continued device growth. Now, does this happen in humans? It appears to. This is the IVIS sub-study of the 50-patient proof of concept trial, looking at post-procedure, then in 9 or 12 months, 2 cohorts that are combined for this analysis. Vessel area increases significantly. Bioadapter in stent area increases significantly. Lumen area is effectively not changed. This is also supported by the QCA data, same patients. Baseline post-procedure, then at 9 or 12 months. If you look at the bottom, in bioadapter, which is in stent, late lumen loss mean median of 0.11, 0.03, which is some of the lowest reported. And what appears to be the case is we know, as I said, the metal device cages the vessel, second-gen DES, the neonatal hyperplasia, which is 140 micron, can only go in one direction, the wrong direction. Whereas dynamics bioadapter that appears to have the capacity to increase device and vessel area can accommodate that neonatal hyperplasia. And the hope is beyond a year it will accommodate new disease progression as well to maintain flow rate. Look for a head-on US IDE trial. I think I can't say what it'll be against, but that'll be in 2022. You know, it's been a remarkable evolution here. We had a brief discussion before we started the talk today in drug-coated drug-eluting balloons. And I think this is a new horizon for us here in the US. There also been some interesting, I won't say posturing, but developments for the FDA that we'll get into in a second. I think everybody here knows the first generation paclitaxel-coated balloons are approved for peripheral use in the US. They have crystalline and crystalline amorphous coating that are fraught with challenges, frankly, particularly pre-microembolization, drug loss, and transfer. You know, it's been estimated by Juan Granada that only 10% or less of the drug on the surface of these devices actually gets to the target tissue. I thought the next shoe to drop would be the second generation sirolimus-coated balloons. I thought those would already be in clinical trials at this time. Interestingly, despite the clouds that have swirled around excipients, particulate debris, and paclitaxel-coated balloons, the FDA has allowed Agent from Boston Scientific. It's already approved OUS. We're actually a high enroller in this trial at this time to come into the market in a clinical trial, randomized clinical trial. And the Sequent Please by B. Braun is also a paclitaxel-coated balloon. That's going to initiate its clinical trial, I suspect, in the next 30 days, frankly. Now, despite that, 2 paclitaxel-coated balloons already in clinical trials, if you will, in the US at this time. The second generation sirolimus, I think, is a more attractive drug in the coronary. There's less late loss. Therapeutic window is much greater with sirolimus than it is with paclitaxel. Historically, this has been the drug of choice for coronary application. Now, although these drugs all use sirolimus, they have widely variable coating technology. I think 2 of these are still going to be in clinical trials within the next 6 to 12 months. The Concept Medical Magic Touch uses nanoencapsulation sirolimus between 2 excipients. The metallized solution has a PLGA, a polymer transfer membrane, somewhat akin to the concept of gel paving, so to speak, to move the drug and to stick it on the wall of the artery. And the Sequent Please sirolimus, yes, Sequent Please has the paclitaxel and it also has a sirolimus. Uses a V4 spray-on excipient. The efficacy of transfer drug with these devices appears to be significantly improved, and at least 40% of the drug on the surface of these devices gets to the target area. There is a third generation sirolimus eluting balloon. This has been classified as a breakthrough device by the US FDA. Sirolimus is a drug, but there is no coating, no particulates, no drug long transit. This is the Virtue sirolimus eluting balloon catheter. It has 4 to 6 micron laser drilled pores throughout the surface of the balloon and employs a proprietary bioresorbable nanoencapsulation technology called sirolimus EFR for extended focal release. And all I'm allowed to say is that there are little pillars of packets of sirolimus that are extruded through these pores into the wall of the vessel where they undergo programmed resorption. This yields the pharmacokinetic profiles shown here on the right using normalized tissue kinetics, normalized for day one concentration with virtue in red. They mimic the pharmacokinetic profile of cyclins IX DES out to 30 days. Virtue achieves a therapeutic concentration, as shown here in the wall of the pig artery that extends out to 30 days with little drug loss in the kidney, liver, and lung. Well, the pivotal trial for US FDA approval will focus on in-stent restenosis. This is a void in our armamentarium, as you guys may or may not know this. There's only 3 devices approved for the treatment of ISR in the United States today. They are POBA, plain old balloon angioplasty, taxa stent, which is totally extinct, you can't find it, and vascular brachytherapy. Many of you may not know that restenting with a DES is not an approved indication. So all of these trials, including agent, sequence, please, virtue, will target ISR as low-hanging fruit for their initial approval in their IDE. Patients with previously treated 1 or 2 stent DS or BMS ISR who satisfy these lesion and vessel criteria have to be pre-dilated to a less than 30% residual stenosis before they're randomized. And this is the same as it is in the EJ protocol as well. If they're a single stent ISR, they're randomized 2 to 1 to virtue of POBA. POBA treated patients, if they have a recurrent ISR in the coming year, can cross over to active treatment. So these patients get 100% access to the technology. The primary endpoint, TLF, powered for superiority at 1 year. In this trial, the 2 stent ISR will be given open label treatment as a single arm, non-randomized pathway. The primary endpoint is TLF after 12 months. The 2 stent ISRs are also randomized, if you will, in the agent trial. You know, the next shoe to drop that everybody's waiting for, and the IDEs have already been written, and that is small vessel randomized versus small vessel stenting. You know, to quote my good friend Antonio Colombo, why put metal in a small artery unless you have to as a default strategy? And I think this is really going to be the next horizon. This just came, I think this is this month, if you will, JACC-CI. It is the randomized comparison of the PET sequence, please, paclitaxel coated balloon, which is now going into clinical trials in the US versus taxa stent, which is said is extinct, and 3-year follow-up looking at target vessel revascularization in small vessels. These are vessels that have a 0.25 or less diameter. And what you can see, at least in diabetics over 3 years, there's a significant reduction. The concept of leave nothing behind, medicate the artery without leaving a metal scaffold appears to have a greater impact. And you can imagine going forward in small vessel randomized trials of stent versus drug-eluting, drug-coated balloons. I think this will be one of the pre-specified and stratified subgroup to be analyzed. You know, I think last but not least, we've hit a real never in our history, if you will, it's a perfect storm. Has there been, has vascular calcification been such a problem or issue for us? The aging population we work on, the prevalence of explosion, epidemic of diabetes, chronic kidney disease, they never in our history as interventionists has large bore catheter access been more important than it is now. You know, the miniaturization of technology has made EVAR, TVAR, TAVR, and mechanical cardiac support. These are everyday events at our centers. And the access of choice, of course, is transfemoral. This has a lower complication rate, lower mortality. Unfortunately, half of these patients have moderate to severe calcium in these vessels that can preclude access. It's worse below the knee. Half of these patients are diabetics, up to 75% of them have moderate to severe calcium in the coronary circulation. This is 25 to 30% have moderate to severe calcium. Well, calcium really can impact the outcomes of PCI. It's a meta-analysis, 7 contemporary PCI trials, clinical outcomes to 3 years. Those patients that had severe target lesion calcium as defined have a significant increase in death MI, repeat revascularization. I've often referred to calcium as the gift that keeps giving. If you look at the Kaplan-Meier curves on the left, the composite at death and my revascularization, through 3 years, these curves continue to diverge with incremental hazard associated with the presence of severe lesion calcium. If you do a 1-year landmark on the right, even beyond 1 year, there rapidly evolves incremental hazard associated with severe lesion calcification, likely reflecting restenosis and thrombosis. Well, calcium can impact stent symmetry, apposition, and expansion. The greater the arc, length, or thickness of calcium, the greater the likelihood of stent under expansion. Asymmetric stent expansion has been seen in up to half the stents deployed in calcified lesions. And by multivariate analysis, stent under expansion is the most powerful predictor of stent thrombosis and stenosis. On the right, you see the relationship between the arc of calcium in degrees on the horizontal axis and the degree of stent expansion with a 16 atmosphere deployment on the vertical axis. It's very simple. If you draw a line at 180 degrees, nobody that has an arc of calcium greater than 180 degrees achieves over 90% stent expansion, which is a benchmark for optimized stent outcomes. You know, our toolbox for calcium modifying technologies continues to grow. It begins on the bottom left with these NC cutting, scoring, balloon, rotational, orbital atherectomy, ablation, and most recently, intravascular lithotripsy. I think we're really fortunate to have an algorithm for the treatment of moderate to severe calcium. You recognize this as the sky position paper. It was co-authored by 2 of my partners, Rob Riley, who's now back in Seattle, Tim Henry, you all know. And it incorporates calcium modifying technologies in the toolbox, if you will, down here on the right, as well as stressing the importance of imaging. If you've got moderate to severe coronary calcium, or you have a non-dilatable lesion, you really should do vascular imaging, preferably with OCT with better resolution for calcium overall. And if you have an arc of greater than 180 degrees, based on the data I just showed you, you get 2 points, length greater than 5 millimeter, 1 point, thickness greater than 0.5 millimeter, 1 point. This is the calcium volume index score. If you got 4 points, the likelihood of getting stent under expansion exceeds 80%. You should reach into that toolbox, and as we say down here, get you one of these calcium modifying technologies. If your score is 2, you may want to give it a go with an NC cutting scoring balloon, but make sure that you have full inflation of an optimally sized balloon before you put in the device, the stent. If you can't, you need to get into the toolbox and get a calcium modifying technology. Thanks to Akiko Miyahara, who provided me with these images. I think this is really important. One of the real challenges with the anteroablative technology we have today is the wire bias effect. You know, I tell patients all the time, don't worry, that drill knows where to go, it rides the wire. Well, it sure does ride the wire. This is an eccentric rut or trough, a very exaggerated example, but true example from Akiko, that literally engulfs the OCT catheter and wire distinct from the lumen. You see somewhat similar type of eccentric impact, if you will, for orbital atherectomy. In the upper right corner, you can also see an incredibly beautiful, thick, deep arc of calcium. You got to ask yourself, how does that device access and modify calcium at the level of that asterisk? The answer is extreme wire bias or increase in the size of the burr, neither of which are particularly attractive. This is hot off the press from DCIS registry. It summarizes the experience with rotational atherectomy in UK. And what you can see is year over year, there's between a 1.5 and 2% risk of perforation. And this has been constant over time. Perforation with 4-fold increase in rotational atherectomy PCI versus all PCI. And however you get your perforation, there's an increase in both 30-day and 12-month mortality, as well as increased hospital days. And then we have intravascular lithotripsy, which applies the technology been used for over 30 years to treat kidney stones. Acoustic pressure waves are generated from emitters placed on the shaft of the balloon angioplasty catheter. They emit 1 wave per second each a millisecond, transmitting 50 atmospheres of pressure in a circumferential transmural fashion. Balloons inflated at 4 atmospheres, 10 pulses are given. Balloons then inflated to the nominal 6 atmosphere pressure. If full balloon inflation doesn't occur, the balloon is deflated, reperfusion occurs, cycles repeated. Eventually, full balloon catheter inflation at only a nominal pressure of 6 atmospheres should be achieved. This is a modification of sonic pressure waves that have occurred in the evolution from extracorporeal shockwave lithotripsy, shown here in red, which is used to fracture kidney stones, to intravascular lithotripsy, shown here in blue, where there's a marked reduction in positive and negative peak pressures to minimize and actually eliminate trauma to non-calcified tissue in this effort. In addition, there's a fluid-filled balloon which facilitates heat dissipation. The mechanism of action, we think, is multiple longitudinal circumferential calcium fractures, as shown in this post-IVL OCT image. I think this was from our JACC paper on the bottom right. You can see fracture expansion here with stent deployment, which we think is a mechanism of increased transmural compliance. Well, DISRUPT CAD III was a pivotal trial for US FDA approval. It was prospective multicenter single-arm global IDE conducted in 4 countries. Patients with heavily calcified de novo coronary lesions were enrolled. This definition included greater opacities on both sides of the vessel, at least 15 millimeter length by angiography, or a calcium angle at least 270 degrees by intravascular imaging. One enrolling patient per site was allowed at each of the 47 global sites. An additional 384 patients were enrolled into an ITT population in which the primary endpoints were discerned. From these populations, we segregated 100 patients in the OCT substudy were enrolled. You know, the primary safety endpoint in DISRUPT CAD III was freedom from MACE at 30 days. This is the exact same safety endpoint used in the ORBIT II trial, the pivotal trial for orbital atherectomy approval. And the primary effectiveness endpoint, procedural success, was the exact same effectiveness endpoint used in the ORBIT II trial as well. That said, freedom from 30-day MACE, the primary safety endpoint was 92.2%. Even the lower confidence bound of that figure far exceeds the safety performance goal established from ORBIT II. The primary safety endpoint was met. The procedural success, primary effectiveness endpoint, this is 92.4%. Again, the lower confidence bound far exceeds the effectiveness performance goal established from ORBIT II. The primary effectiveness endpoint. You know, this slide shows in-hospital 30-day MACE rates in CAD III of 7 and 7.8%, along with some of the individual components of MACE. Recall that in ORBIT II, a trial with similar population, similar endpoint, similar definition, the 30-day MACE rate was 10.4%. This is one of the revelations, I think, of the entire experience with IVL. This is pooled patient level analysis of CAD I through IV, 628 patients, 72 sites, 12 countries, multiple continents. Doesn't matter where the procedure was done. The safety endpoint was consistent across all of these sites, countries, and continents. This is the angiographic complication rate, which is remarkably low. In CAD III, 2.1% of patients had a type D through F dissection. This was reduced to a single patient, 0.3% following stent deployment. And note the perforation, abrupt closure, no reflow were 0 post-IVL alone. When you expand this to 628 patients, 72 sites, 12 countries, multiple continents, it doesn't change. Perforation, abrupt closure, no reflow remains 0 after IVL. Well, every novel technology is a learning curve. I think this slide summarizes the first case at each of the 47 international sites here in orange, 47 compared to the subsequent 384 enrolled into the pivotal IDE trial here in blue. And you know, the clinical and angiographic characteristics were similar between these populations, and remarkably, primary safety endpoint, primary effectiveness endpoint, even device crossing were not different from the first case compared to the next 384. These are, in closing, some of the OCT examples that were presented by Schlockmitz at TCT last year. We actually have 3 OCT abstracts being presented at TCT this year. I can't show you those data, embargoed, but they're directionally highly consistent, let me say that. The maximum calcium in 100 patient cohort at the site of maximum calcium, which was defined by the maximum angle. If 2 angles were equal, then the one with the greatest thickness also at that site moved up to the site of maximum calcium. 293 degrees was the average, with an average thickness at that site of almost a millimeter, 0.96. Now, despite that level of calcification, the average stent expansion at that site is 102%. The MLA, the MSA, minimum stent area, if you will, is 6.5 for the whole 100-patient cohort. This shows the outcomes by visualized fracture and no visualized fracture in the expanded OCT analysis of CAD 1 through 4. They're very similar. 70% of patients have a visible fracture, 30% don't. There was no difference in these data from CAD 3 in the MSA, the degree of stent expansion, or the area of stenosis in the minimum lumen area site between those with fracture and those that don't. Now, you heard me say the mechanism is fracture. Am I wrong in this? I think some of these are off plane. We could have missed it. Others, I think, are beyond the resolution of OCT. I'm not kidding. There's data in support of that from the preclinical data using micro CT to a microfracture from Renu Vermani's group. And the last is there could be some other mechanism that can modify arterial compliance. Well, in summary, I'd say that the stent-related adverse events are influenced by stent strut thickness. The role of stent geometry remains to be determined. Fracture is a common mode of stent failure. It's inversely related to stent flexibility and presents as restenosis thrombosis. You know, there's 2 to 3, 2 to 4% annualized rate of adverse events beyond the first year of stenting, regardless of device, appears related to the common presence of a metallic prosthesis that continues to constrain and distort the vessel. The ability of dynamics bioadaptive to impact that annualized rate remains to be determined. A drug delivery without a scalpel will undergo the evaluation for ID approval, first with ISR, but then in small vessels where the impact of strut volume is clearly exaggerated. And vascular calcium increases PCI complications, impedes late outcomes after stenting due to malopposition under expansion. And as I've shown you, IVL safely improves transmural vessel compliance, reduces fibroelastic recoil. We can talk about that, the MLD following IVL alone, and it mitigates the need for high pressure balloon inflation and barotrauma by creating multi-plane circumferential and longitudinal calcium fractures. Thank you very much for your attention. I think I ran a little bit beyond. Any questions?
Dr. Kereiakes, that was a truly wonderful and educational talk. I truly enjoyed it. Especially the slides were spectacular, and it was great to see the trial data and the histology and the imaging side by side. It was really awesome. You took us wonderfully through all the key stent properties that determine lesion failure, which are a central focus of research. And as you said, these advancements embody the evolution of interventional cardiology from the perception that we had of balloon jockeys to where the field is now. And, the innovation in drugs, materials, and biomechanics is just mind-blowing. We obviously look forward to trial data on all these novel stent technologies, like you mentioned, like the DYNAMIX and the bioadapter study and treatment of small vessel disease. That's truly an awesome talk. Let me just see in the chat. Does anybody have any questions? You could either put it in the chat box or just unmute yourself or raise your hand. And so let's see. I think Dr. Adran put a message in the chat box, but I think it just came to me by mistake, but I'll read out the question. How close are we to having coronary drug-coated balloons in the USA?
Yeah, I think we're, probably within 2 years. I think the Asian trial is enrolling quickly. We thought it would be really painfully slow. We've been able to enroll more than we thought. It's 1 or 2 stent ISR. They're randomized 2 to 1. To either the drug-coated balloon or POBA. Again, we actually showed the Virtue study design probably 2 years ago. I think the first I showed that at CRT. They bid on it. Others have said, no, you can't randomize the POBA. You got to randomize DES. You sit in front of the FDA and you tell them it's clearly not an approved comparator. I mean, you want to, look the other way and say we're going to randomize. And the fact is, the POBA is an approved comparator. It is what we have. It is done, particularly to bail patients out. So we allowed POBA to be done, even if somebody came in with say a non-STEMI, like they often do. you can balloon them, and that doesn't eliminate them from randomization. They can come back in to us within months. They're going, and if they're restenosed, we can take a look. They can be randomized at that point. So an additional balloon procedure doesn't exclude them. I think it'll be 2 years. You're going to probably have or less. This trial will be closed. Bobby Ye's the PI, and I think for agent, it'll probably be on the shelf, I would think, unless there's something wrong with it in the next 2 years. But this is widely used in Europe, as is the sequent please. So I think they've got the lead. I still believe overall, whether it comes true or not, that sirolimus is the drug of choice in coronary application, particularly for smaller vessels. And I think that would be my bias. Okay.
So Dr. Kereiakes, do you, so all of these trials, that you mentioned that sort of pit one stent technology to the other, or, they often enroll patients who have stable angina or unstable angina, or maybe like low risk end STEMIs. Do you think there are any caveats we should think about when we're, dealing with similar lesions, but in a high risk end STEMI or a STEMI situation? And do you think there are any caveats for stent technology in that?
Yeah, we had a lot of hope for Leave Nothing Behind in the STEMI population because they're usually lipid-rich plaque, lipid pool. And you've seen the data regarding lack of healing at times in stent struts that are placed deep into a lipid pool. But it didn't, I don't think this is, it hasn't panned out. Every trial in the US uses biomarker positive, and that's really undergoing, as you know, because of the stealth trial, optimize or reevaluation the use of high sensitivity component. In fact, Greg Stone is combining our data from SPELT with data from Medtronic's trials and looking at high sensitivity component, where unless you put the bar higher, the question is, really, should you use high sensitivity component at all? And I mean that. We had similar between the two randomized devices, SPELT or Chromoscience, about a 30% periprocedural MI rate in the centers in optimize. They used high sensitivity component. So it aberrated the endpoint TLF, made it high and underpowered the trial because of the higher observed than predicted TLF rate at 1 year. So I think if you're going to use a component in the non-STEMI population or for periprocedural MI, there's going to have to be some qualification. I think that's going to be a higher multiple upper limit of normal. For example, at least 5-fold regular component plus clinical correlates. You're going to have clinical correlates to qualify somebody as a periprocedural MI. All these devices go for an MI indication. You notice I said MI, not STEMI, because they have the 25-30% of every series is biomarker positive. So they qualify that as an MI. STEMI, for some reason, it's been much more difficult to include. Although the biodynamics, the dynamics bioadaptive is going to include STEMI patients as well. And we think that because it's going to be largely US trial, that'll be probably 10% or less. It's harder to enroll those patients in the US, I think, as part of a trial like this. Frequently they come in the middle of the night, odd hours, off hours. You have to have research staff that's there and can help, to get informed consent and get the patient signed up and execute the process and protocol. So I think we're targeting 10, less than 15% of patients will be STEMI and the dynamics bioadaptive if the IDE proposal gets accepted as is now. But for most part, every major trial you guys have been involved in, including Pioneer 3, for what it's worth. The diabetic subset, the biomarker positive. It always depends too whether you stratify by that, whether the trial is large enough that you can create a randomized trial within the trial by stratifying the randomization. That's a very important strategy, but you have a limited number of variables you can do that for. That really gives you an insight into the relative benefit or lack thereof in that population that is stratified prior to randomization. These pre-specified subgroup analyses, I mean, they always go usually in the direction of the trial as a whole, and it's really not as scientifically bound.
Questions in the chat box here. So I'll ask another question about small vessel, lesions, and you mentioned the role of drug-eluting balloons and such. So is the determination of eligibility based on angiography for these trials for small vessels? Because a lot of these small vessels, people have diffuse disease, and on IVUS imaging, etc., the vessel is actually much bigger. How does that play a role into choice?
Yeah, I think it's going to have to be visual estimate, which we learned that from the Absorb 3 trial, BBS. A visual estimate of 2.5 equals a QCA analysis of about 2.25. There was that systematic variance at that level. I think that was really a problem for a stent that had not just 157 micron thickness, but 140 micron width. Now, we all know Cypher. Many of you guys don't know because you're young enough, but Cypher was 153 micron thickness, 60 micron width. Cypher had some thrombosis, but when you go into vessels less than or equal to 2.5 with a strut volume like BBS had, the increase in footprint, the surface area, coverage, and the relationship of strut volume to vessel volume, it exceeds 10%. I mean, it just exponentially ramps up. So I think I've been an advocate for years of small vessel stents designed for small vessels. If you ask me what stent would I put in, 2.5, 2.25, what I'd like to put in, I know what we have on the shelf. It would be one with a ultra thin strut in general because of the data that I showed you. It has not just theoretic appeal, but it has some objective appeal based on these analyses that I showed you. Would it be better to leave nothing behind? I think that's going to be the test. If you can get a crossover, meaning don't dissect the vessel, deliver the drug without a metal scaffold, and keep your crossover up front to bail out stenting at 10%, which some of these trials have done, I think you're going to have a real advantage to medicating the artery without leaving a scaffold behind, particularly in small vessels. I've said this for a decade, and Boston made the Megatron instead of a Thin Man. Never came about. Alexander's probably smiling. She remembers the comments that made of Thin Man rather than Science. For Abbott, they never developed the ultra thin device. Now people are starting to look at it. And we're going to have this head-on comparison in short order. Every drug-coated balloon company is going to want to take that on. If you look at Japan as a bellwether, probably 20% or more. It could be even higher, but their small vessels are done with drug-coated balloons, not stents. Obviously, you get an ISR in a stent placed in a small vessel, it's a problem. You're not going to re-stent it. Look at the metal volume you put in, even with 80 micron strut thickness. It's really, so I think that small vessels are the horizon. And if you look at the use in every trial, it's at least 25% or 2.5 or less. So it's going to be a huge component of the US stent DS population. And I think will open up, more than some people are reticent to use 2.0 stents like the ONYX. It'll open up the smaller vessels too that may be intervened on, okay, to the extent that they're important in causing objective ischemia. So I think this is, I think that's the next horizon. I'm real excited about it. The ISR is the low-hanging fruit to get on the market, and then people will be using it for other purpose, but they'll have to be clinical trial demonstration of safety and effectiveness in randomized trial for small vessel.
Well, we're past 8:30. So Dr. Kereiakes, again, thank you so much for taking time out to talk to us. It was a truly wonderful talk, and I'm sure everybody enjoyed it. I look forward to meeting you at some meeting or someplace. Thank you again.
Hopefully we can. Thanks, guys. Really
Bye.
appreciate it. You bet.